All right. Well, good afternoon, everyone. Welcome to the UCSF-Stanford CERSI FDA Cybersecurity Seminar Series it's on cybersecurity for biomedical engineering, with a primary focus on the healthcare delivery and medical devices. I am Kevin Fu. I'm your host and moderator, and I'm from Northeastern University, where I direct the Archimedes Center for Healthcare and Medical Device Cybersecurity. A couple disclaimers before we get started with today's seminar. This series does not represent official FDA policy or guidance. The contents are those of the speakers and do not necessarily represent official views of nor an endorsement by FDA, HHS, or the US government. This seminar is being recorded. And just to head off the question, the slides will be available as a video posting some days after the event, and it'll be on YouTube. A little bit about myself. Again, I'm going to be moderating today. You can always find me on LinkedIn if you want to know more. Suffice to say, I care deeply about protecting healthcare and medical devices from cybersecurity threats. So why are we here today? Just a reminder, for those of you who are new to the seminar series, there are just so many headlines in the last several years about healthcare systems under attack from things like ransomware. Ransomware bringing down not just healthcare delivery, but also the plumbing of those systems, essentially, right? The financial reimbursement systems. And it's been paralyzing in the United States over the last year. We've also got security solutions that have inadvertently disabled US hospitals. And so we're probably going to see more of these in the future as we begin to discover just how fragile our critical infrastructure is. So how are we going about addressing this, and what are some of the solutions that are a combination of public policy and technology? Well, there have been laws passed, there's been legislation. The Patch Act was introduced via the Omnibus Bill over a year ago, and there is now draft Section 524B guidance that FDA published earlier this year about how they're going to implement the congressionally mandated cybersecurity requirements for medical device security. And at the same time, there's quite a bit going on in the standards community. The Health Sector Coordinating Council, AMI, and other organizations are working hard behind the scenes to produce frameworks for not just healthcare delivery, but also medical device manufacturers to have a coherent way to design security into these systems from the get-go. Just a reminder, since this is an FDA partnership, there is guidance out there on this, and some of it has already been finalized. So the Cybersecurity and Medical Devices Quality System Considerations and Content of Pre-Market Submissions, that was finalized over a year ago now, and is essentially the engineering requirements, what the reviewers are going to look for if you submit a medical device for pre-market notification, pre-market review. And you can also find some of the other draft guidance along the way on the FDA cybersecurity landing page. So we've had over 22 speakers in the seminar series before, ranging from clinical to technical and public policy. And we have a couple more coming up. Just an announcement, the November seminar will be by Jan Kufner from TUV Sud, and he'll be talking about pen testing of medical devices. Today's speaker is Andrea Greene-Horace, and she is joining us from HHS and the Centers for Medicare and Medicaid Services. And today she's going to be speaking about the hot topic, right, of protecting the hospital landscape against ransomware attacks and the loss of life. And without any further ado, I'm going to stop my screen share and allow Andrea to present her slides. But thank you, Andrea, for taking the time to join us and give your remarks.
And thank you so much. And I appreciate Stanford and CERSI and the FDA allowing me to speak today. Just as was mentioned, this is my presentation is not endorsed by anyone at HHS. These are lessons learned, and they they are my own opinions. So and time. So I just want to make sure that that is said as well. Just a little bit of background. So I want to tell you who I am and who I'm not. I actually started my career, and I'm trying to get the slides back up. It looks like I just lost it. So hold on here. I actually started out as a non-IT cyber person. So when I think about this, this is probably a very untraditional path to getting to where I am. I actually started out wanting to basically spend time becoming a doctor. And obviously after going to college, I decided that I really couldn't handle spending time in hospitals because I was allowed to do some hospital in internships, but I decided that that was probably a bit too much, and kind of gravitated to health administration. Ended up going to Cornell, where I actually got a degree in healthcare administration. And during the time, I decided to take my first and only comp science course, and didn't know how that would actually change me. But after school, after getting my master's, we were in a recession. It was really hard to find a job. And if you can remember, during that time, managed care back in the 1990s really changed the way that hospitals and doctors were doing business. So there were a lot of doctors that I knew at that time that were going back to get their MBAs because they were trying to figure out how to, certainly keep their profit from that. And what happened after that was something very, very amazing, because there were a lot of healthcare organizations that were growing. So those doctors actually took time to actually think about what they were going to do next. Some of them obviously stayed with hospitals. Some of them started to develop group practices. And then I think that's how you started to see the healthcare landscape really changing. Hospitals started to acquire other hospitals. And what we saw was a consolidation. We had a lot of more for-profit hospitals coming up. So I had a chance to actually work with even non-traditional organizations like the Marriott Corporation that actually started to do assisted living. So I actually helped them to start their first standalone assisted living facility in New Jersey. But of course they got out. But at that time there was a tremendous amount of organizations, and I also helped a group of physicians in New Jersey to also to develop a management services organization. It was a good time, and obviously more into IT. Around that time, I decided to go to CMS, using more so my policy skills. I thought to work on some efforts, but I was kind of drawn into the modernization effort. Medicare managed care was growing at that time too. So I was able to kind of take some of my hospital knowledge, and at one point I actually worked at a federally qualified health center that actually started their own managed care plan. So when you think about untraditional healthcare organizations really trying to modernize, there was this federally qualified health center that actually in Syracuse had developed their own Medicaid managed care organization, which is really revolutionary around that time. But once again, that changed with consolidation because of managed care and everything else. But I did end up working on the IT modernization effort, and decided at that point I wanted to kind of do something different. And I had my daughter and wanted to be closer home. I ended up going to work with the IRS, because I thought by that time, well, I know a little bit about IT policy. My commute was very, very long. Let me work with the IRS. It's 15 minutes away from home. And I ended up walking into the biggest IT modernization effort that the IRS had. They had not updated their master file of every organization, whether you were an individual, a small, a large, or a mid-sized business. So every tax-paying entity or organization, they had to update everything, including their master file. I had a chance to actually work on their strategy piece, how that was going to come together, and then later working in their capital planning and investment IT control portion in terms of making sure that the IT investments were sound and that we had budgeted correctly, and then ended up at the very end working on their program oversight, which really work with Congress and other IT auditors, just to make sure basically that any investments were following, obviously big regulation. So around that time was when we were calling it information assurance, when we were talking about defense and depth. So I had a chance to literally on the way home, stop and answer questions from congresspersons who would call the IRS to find out what they were doing, because at that point, obviously that was one of the big efforts. Didn't think I'd ever get there because, once again, I started in healthcare. And then something very important to me, I didn't lose my healthcare passion. And then obviously President Obama started the cybersecurity, started the Affordable Care Act. And I thought this is a real good opportunity for me to use my skills. And just prior to that, I was tapped by Lieutenant Governor Anthony Brown to work on the Maryland exchange. But when I worked for that effort, I actually worked on plan management because I had still some depth in the healthcare arena, and I didn't work on the IT side. So when I actually got over to HHS, the Centers for Medicaid and Medicare Services, to help out, I thought I was going to be the health plan policy person, which I was really excited about. But they asked me one simple question. They said, because you have this healthcare background and you also have an IT background, what do you think is missing here in our strategy? And I said, honestly, I think it's privacy and security. And from there, for the Affordable Care Act, there were two big efforts that were undergoing. One was to make sure that those state-based marketplaces, those governors that wanted to take money to develop their own state exchanges, that effort had to be started up. And then there was the other effort for the states that decided not to take the grant money, which was under the SFM. So I actually led the development of making sure that cybersecurity and privacy was built into those 17 state marketplaces. So, and you can imagine, even that sector, when you think about it, CISOs weren't necessarily around. So we spent time working with the CIOs to make sure that they obviously brought on the appropriate people. And we made sure that, obviously NIST definitely, they NIST a suite of documents, particularly 853, the agency plus the other federal partners, whether it was the IRS, whether it was the Department of Justice, they all basically agreed that there would need to be, obviously an agreement that if they were going to partner, including other organizations, that they would have to make sure that they considered 300 controls that we picked from NIST and looked at also OSWAP. I never think I say that correctly, but also those things that were kind of threats that were coming up, that they would build those things into. So, and then how I got to staying was, obviously staying, and not only that, but how hospitals became a passion. Hospital safety became a passion because obviously as a mother and a wife and as a human being, my family has had a lot of, medical issues. And even if you don't, it can become overbearing when you think about what happened during the pandemic, just the number of cyber attacks, and you think about how the healthcare industry certainly was one of the ones that were hammered. And if you can remember that there was a ceasefire at some point where even the ransomware attackers said basically that they were going to stand off. So when I really thought about it, if I had to focus my extra time, I was going to basically look at hospitals. And I decided to actually go back to school to actually get an official cyber degree from Brown, where I got my executive master's in cybersecurity during the pandemic. So it was a nice case study while I was, certainly, upskilling my credentials, to really watch this thing happening with the hospitals during the worst time it could. And everyone knows that obviously cyber attackers, they wait to they wait to the holidays, they wait to the weekends, but then we understood that they wait to pandemics too. So so once again, why focus on, obviously, why focus on hospitals? that the hospital landscape, all hospitals are very, very important. Obviously, the acute care hospital is very, very important if you happen to be a rural hospital. If you are a tertiary care hospital, then that's when you really have a very specialized set of skills. So when I think of Brigham and Women's Children's Hospital, that really does something special. When I think of things like the Mayo Clinic, not that all hospitals aren't important, but those that if I had to get transferred to, or even in your regular hospitals, I think about things like pediatric care units. I think about the ICU. I think about the surgical suites, and that as a parent, I thought, oh my goodness, this is happening. And my daughter, and I actually had surgery during the pandemic. So not that it was on my mind constantly, but I thought, okay, this is very, very interesting. I'm hoping that the hospital doesn't close before. Now, living in the Washington, D.C. area, we're very fortunate because obviously we are very well capitalized, but I do think about other organizations, and then obviously those organizations that are level 1 trauma centers that have really that are fully staffed. But obviously this is where these places in just regular hospitals, whether they're your cardiac neonatal units, they really need to be protected. So when I think about business continuity, if I had to tell a hospital, obviously not that everything is not important, but even in terms of enhancing their coup plans in terms of what their missions are. Yeah, the mission happens to be patient care, but to me, in my opinion only, when these things happen, we want to make sure that those patients that are at the most critical and in need, that could really succumb to injuries or need to be transported, there needs to be really an opportunity for them to really plan and make sure that their continuity plans, that their devolution plans, even transferring to other places, and then even if they have to devolve, if they're on the cloud, is there another, is there a way that they could devolve elsewhere? And we're even thinking about it now when we think about the industry, really taking it seriously, that if you're on one cloud service provider, what happens if that cloud service provider for some reason doesn't, is having a major issue? Are there agreements there that would allow them to devolve? So as I said, this became a passion because I just thought about everyday life and just the effect that it's had on just others in the community. And I do remember one article where I did read that there was a surgeon in Russia that was actually doing a surgery on a young teen, brain surgery, and the actual hackers were, I guess it was for ransom, that they wanted something from him. But once they figured out what was going on, they apologized. Well, obviously everyone doesn't apologize, so they were able to thwart that. But it is certainly something interesting. So let me tell you just really quickly where I fall, and I think many of you guys know where you're pretty familiar with HHS, but my agency happens to be the Centers for Medicare and Medicare and Medicaid Services. And when you think about it, we really have kind of oversight for the Medicare program, the Medicaid program is state-based, and then obviously not just state children's health insurance program, but also the nursing homes oversight as well. And then there's Marketplace. So the 3 M's, Medicare, Marketplace, and Medicaid. And my area of responsibility, as I said, at one point, was setting up the privacy and security office for those 17 state-based exchanges. And it's been morphed because I tend to do things that kind of are like startup projects. So I've actually worked on something that was called their enhanced direct enrollment program, where it allowed other web brokers and other kind of insurance or organizations to participate, and really making sure that they understood what some of the requirements were for getting involved on a privacy and security basis. Right now, I do work with the continuity of operations for the ACA to think about and certainly make sure that there is an opportunity to plan for should there be a continuity event, and not only a continuity event that would be in the area, but if we would need to devolve to, outside of the capital region. Obviously, just because we here in Washington, may not work, it doesn't mean that we can't continue our operations externally by devolving to another region. And when we say devolve, that means that it's just not only our people, but obviously making sure that our systems can devolve, which means that working with our vendors and with key arrangements. As I said, and I'm not going to go through this again, but as I said, my interest really peaked during the cyber event, during the COVID event, during that time when we were right in the middle of having to need several surgeries and operations on ourselves. And obviously, if you're a student studying it, as I was at Brown, I thought, okay, this is very, very, very interesting. But it was a nice comfort to think about, the things that were already done. And around this time, Mark Warner and others were looking at, introducing bills. So this became, obviously, once again, as I said, a passion project. But obviously, when you think about just the increasing threat level, it is still something on my radar. We can talk just really quickly about the impacts that are already out there in terms of patient care. But obviously, there was a case back, I believe, in 2019 where a baby allegedly died as a result of computer outages. And I understand now that obviously the hospital was, I'm assuming that they did admit that something did happen, and I know the family is still looking for payment, which I think they're still working out. But that was something, as I mentioned, the Russian surgeon, and then obviously something that obviously became an interest to all of us. We talked about Vice President Cheney not using something that would have helped him in terms of his defibrillator, because he was very, very concerned. And obviously they talk about upticks in fatal heart attacks when these things happen. So we do know basically that that given as Kevin presented, there's a lot going on with not only just healthcare, but because our 16 critical infrastructure sectors, and obviously or organizations like Change Healthcare, the industry really really has started to come together to not only look at how hospitals can really strengthen their cyber resiliency, but also looking at those endpoints, which happens to be something simple to me, as as we said, change, but obviously we know that from the target breach, the HVAC system, very, very important too. And then obviously just thinking about water and infection control in a hospital, so all these things are very, very important. Obviously I'm loving that the medical device community has come together, but we have to look at all those things. But once again, they have to be prioritized in terms of really focusing on what those mission critical functions are, and then really making sure that those things, whether they're the HVAC, whether they're the water, because you can't you can't have a safe hospital if the surgeons can't wash their hands with clean water either, and that's being hacked. So obviously we have done so much as an industry just from the time that I was studying to now. And I wanted to talk just really quickly about the perfect storm. So one of the things that I understand, that obviously the U.S. has the greatest healthcare system, and then obviously we encourage all hospitals basically to have the best medical technology, and to adopted really quickly. And then obviously, we used to have something called certificate of need laws, where at one point you couldn't duplicate, the same, technology in the area. You had to really apply to health planning organizations. I remember early in my career wanting to be a hospital administrator, going to the health planning board of the hospital that was seeking to expand access to, I don't know whether it was a large, it might have been an MRI, but they had to apply and then wait. And I know at some point, our Congress said, that's ridiculous. My district needs those things too. So that was relaxed. And then obviously, unfortunately, as cyber grew and other risks grew, the only thing that I recall seeing at that time was, obviously just make sure that you have a coup plan. I think one of the agencies said basically just make sure that you have a business continuity plan, but it wasn't necessarily specified, so there's a lot of opportunity for us to adopt. We're not going to say no to things, but obviously one of the things that I think that we can improve is really recognizing that adopting this requires some level of modernization. And I'm not talking about AI, or I'm literally talking about some of these organizations have tech stacks that are just not ready, so that they just need to be modernized, other than trying to just think about trying to basically adopt emerging technology. It is just literally sustaining the infrastructure, just keeping what they have going, and then modernizing to the point where they can actually somewhat manage. So it's just not about the just cyber services. And I think right now, I know that, obviously that the federal government through its enterprise cost accounting and prospective payment system, we do allow our hospitals to basically, tell us how much they're spending for certain services. Right now, I don't think that we're seeing that visibility in terms of how much they're paying for their IT stack, nor how much are they paying for their cyber services. So that's something that I think can be improved. Saying that, the federal government, we are the largest payer of hospital services. We use something called the Medicare cost reports, which is used by hospitals to receive reimbursement. And each hospital, the HHS under the CMS has something called conditions of participation. And obviously, in order to get reimbursed, they have to fill out, and obviously, hospitals by cost center for some of you are they are paid based on cost center. So that can use that can mean something as the ICU, cafeteria, and depreciation. And we are now giving incentives for hospital to adopt next gen emerging tech. And right now, if I look at that cost structure, that the Medicare cost report, I don't see any indication that there's a space for cybersecurity and IT. I know that it has the electronic health records, but I don't necessarily see that. Now, that's not to say that hospital CIOs or CISOs are not finding a way, but it would be nice for that to be there. So as feds, you have understanding of what this particular hospital looks like in terms of what they're expending on IT costs, in terms of modernizing, or just keeping the infrastructure sustained, or we don't have that. So for IT modernization now, electronic health records, that is absolutely called out, but I don't see that. And that would be nice just from our perspective to kind of get a sense of how is the industry doing. Now, there is some speculation that that 8% of the hospital's budget is spent on cyber. But having that knowledge allows, I think, even Congress to kind of plan, particularly for those hospitals that would be called disproportionate share hospitals that have a higher percentage of Medicare Medicaid that are not necessarily getting, regular insurance or, obviously, out of pocket pay for people that don't need that. But that gives the feds, an opportunity to really get a sense of, how aged is the IT infrastructure, and if we're asking them to additionally to add additional, more protections, I think that would be very, very good. And then really, guiding the industry on that as well. And like I said, I'm extremely happy the Health Sector Coordinating Council is really excellent in terms of really working with what I understand HHS has asked the healthcare organizations to really adopt different strategies for increasing. So there's a lot of good effort going on, and obviously the 4055D, everyone's really working on this. Given that there is an opportunity for conditions of participation, and then obviously we know that the Medicare accrediting organizations like the Joint Commission and the National Committee for Quality Assurance, there is a clear line of authority that allows that information to be shared, and obviously through research too. So even our researchers, because I know that the Medicare cost reports are also used, and I think the organizations, the universities could probably be very, very helpful in terms of helping also in inputting to this strategy. I think this is all hands on deck. So if I had to think about organizations that haven't been able to help weigh in, obviously, because some of these documents can be used, obviously they're sanitized, but they can be used to kind of chart a path forward. But this is one of them that I think is very, very important for how we plan and budget, and making sure that each organization really knows where they stand in terms of how well or how ill they are with preparing for the future. And once again, this just speaks to, obviously, what things can be done here. I think I've probably gone over. Oh yeah, and like I said, because at HHS particularly, we have other organizations like like the giving quality scores on how well hospitals are doing in terms of things like infection control and patient safety. Obviously, you don't want too many falls, but I wonder whether at some point there might be a metric in terms of cyber safety. We've used the Leapfrog group and the Joint Commission at one point to, obviously, to report those things. I'm not sure whether that, but certainly it is, cybersecurity is a part of patient safety. So there are different organizations that I think in the future would be able to, that's a way to inform the public in terms of how safe. But once again, I think all the hospital organizations and I think other healthcare organizations to be very, very, they want what I think the public wants. They do want to do their best. When I think about just my time in hospital administration and in other and then serving in the administrations of other organizations like federally qualified health centers, and obviously, they literally are focused on the patient, and I think even them understanding what they need to do to better. I think there's a lot of information. I think I think I can just probably end here. I don't think I have to go too much further, but one thing I would say that I think it's really, really important is I would hope that we would update the Medicare cost report. I'm not in that realm. Once again, I will remind everyone that I don't work in the Medicare area. I work in the Affordable Care Act area. But the Medicare cost report I would update for just a couple of things. One of them is, obviously, is it possible to make sure, since the industry and government, we're all partners, we're really working. One of the things I would advocate for, once again, is making sure that all the hospitals have access to funding for an independent third party, a security audit. One thing that I thought was really very important as we were setting up those organizations, helping the states to set up, we wanted to make sure, as they built in the privacy and security controls that we took from NIST, that they all had an independent third party auditor, and it had to be a recognized third party or auditor. That's not to say that basically that if they weren't in an organization that had an audit division, that they could not use them. They could, as long as their reporting structures were very, very different. But really having someone to come in who is skilled in this area, when you think about it, DoD is doing it through the CMMC process now, making sure that their supply chain is well before they contract, and making sure that those controls are, but making sure that the third party auditors can give them a real bullseye in terms of producing a security and privacy assessment report, to say that it says, here's how ill or how well you are, here are the things that you need to focus on, because it really gives them a specific plan. I know that the vendors, a lot of the vendors are coming forward, and they're offering a lot of cybersecurity services, and I think that's great. I would encourage that. I think it's important, though, for those folks to have an assessment of how well they are still. And then obviously after that report is done, then it's up to them to develop their system security plans, so they know what they're going to be working on, obviously using, some select controls, whether it's, ISO controls or NIST controls. I mean, I've worked with the NIST controls, and we did consider some ISO controls, to be very, very honest with you. But, and then obviously we, as of the Affordable Care Act, they have to self-test their control, 1/3 of the controls annually, but also we want to test those ones that are key, that have been identified by, places like CISA and OWASP. And then obviously they test 1/3 of the controls annually. On that third year, they come back and they bring the independent third party auditors to come back in, and then managing their programs. And then obviously, you recognize that, obviously, because we're so concerned about making sure that our security is, right, that we make sure that that they manage any findings, whether they're high, low, or medium. We need to make sure that those things were done. So it's a way for the industry and each hospital to really do that. And then obviously interconnection security agreements, even from organization to organization, we want to make sure that the leadership in the organizations, whether it's the board, whether it's CISO, whether it's the IT organization, that they all understand that these connections are, sacred, and that we make sure that those agreements do spell out, certain things in terms of what's allowable and what's not, and that there's agreement on that. Once again, the second thing, as I said, in terms of IT capital investments, as I said, I worked in the capital planning and investment control process as a senior manager over at the IRS. So part of my responsibilities is making sure that Congress knew what and what we were updating during that time of the modernization effort, and obviously, for folks who are in government, you can understand that modernization, development, modernization, enhancements. I didn't put development here, but obviously sustaining the infrastructure was one of the new one, because the new ones for us at that time, because we had to keep the lights on while we modernized, while we were at the IRS. But also, obviously, I would add, obviously, number 7, which is next gen, technology, given that GPT is going to be common purpose technology, so everyone's going to want to do that. So I would add, certainly that there's that we just allow them to spell out, what they're doing in terms of where they are, in terms of their maturity. And I can guess that some of these organizations are going to attempt to modernize, and one of the problems is its aging infrastructure. So that's important. And then lastly, Kevin, before I turn it back over to you, I know one of the things that actually just some folks in the industry are saying is just, obviously, is there a minimum acceptable standard of a minimum acceptable risk standards that are that should be provided. I don't necessarily, I know right now the industry is looking for more so voluntary, and I believe that's been decided that that's fine. But I would encourage even the industry to really look at um, um, special publication 853, just to become knowledgeable about it. I think it's worthy. I know it takes time, but if we do bring in, if we're allowed to pay for hospitals in terms of what they're budgeting and how to figure out how they're well, I think that's an excellent opportunity. It's worked well with the Affordable Care Act. Um, um, Not that it's mandated, but it really helped out. And I can say that, when you look at look at where we come, it's been very helpful. That's all I'll say. It's been very helpful. I think even though it took us a long time, we sat down with everyone in every one of those standards. We added, we subtracted, we had real discussions with the industry. So it wasn't anything that we sprung on them. But we really worked as a public-private partnership as we're doing now. And we sat down with these 17 organizations and the other states to say that they're Medicaid organizations, and say, here's what we're thinking. And we also had contractors that sat in. So it wasn't a push on them, but it was really sitting down with key publications so we could agree and disagree, but at least we got to the point where we were able to trust. And then we're at the point, obviously, where we continue to be resilient and we have things to do. But once again, the way the industry is doing now, obviously, I think having those conversations would be very, very, very helpful in terms of here are really great standards. Is there something we can do? And then maybe have hospital groups and others. And then, not just that, but, we don't want to build, I don't think anyone's going to pay for technology that's outdated when you actually have cloud service too. So we need to talk about what's emerging and what works well, so the hospitals and others that have the most critical patients can certainly flourish. Okay, Kevin, that's all that I have.
Andrea. So we've got a couple questions, but before we get, oh, I'm hearing a little echo. You had an interesting career path. Cybersecurity is a second career. I'm wondering if you could share any stories about this, or help some of the participants who either might be students or perhaps they're already in industry and are thinking about switching careers towards something that involves cybersecurity and healthcare. Do you have any stories or advice you can offer in that space?
So Kevin, I'm sorry, ask that question one more time for me. I just want to make sure that I get it right.
Oh,
I was probably making too much noise.
Okay. Well, I'm curious what you might want to share with someone who's interested in the cybersecurity field. They might be hesitant to explore it as it might be a potential second career choice, or maybe, they're changing from another career. So what might be important for them to know, and, what should they know before taking that kind of step?
You know what? I think folks that are actually looking at this as a second career are probably the people that we really want in the sector. So, obviously the US has 16 critical infrastructure sectors that need to be protected. So that's everything from the chemical sector to the commercial sector to the US public health sector to transportation and so forth. So coming from a second career, that insight in terms of how things operate so important. and not that you can't have, I mean, many people just go into cyber and do very, very well. But also I think having that institutional knowledge is why we need folks who may have started in something totally different. But that domain knowledge is very, very important. So as I mentioned, and I guess I didn't mention, I am not necessarily the technical person. As I said to you, I took one computer science course. However, my area of expertise happens to be domain knowledge, but it's around risk management policy. I've always been interested in policy, whether it's IT or health policy. It is really important to have folks at the table that really understand how things work, so one of the I think one of the things I bring to is having a really great understanding of the healthcare sector. So one of the things that I did not mention is that for the Medicare cost reports to be really updated, it's not HHS's issue. Congress has something called the Medicare Payment Commission, MedPAC. Those are scholars from different universities who are the experts in their field. They are nurses, they're doctors, they're economists, they're pharmacists. They really have a great handle on that. But what I did not see is someone who has an IT background or a cyber background. So wherever your expertise happens to be, that's where we need you. So when I was offered the job, coming from the IRS after leaving healthcare, like I said, I kind of dabbled in, obviously cyber because I had oversight. I'm really glad that when I got there, the organization was really open enough to say, well, you've got this healthcare plan management background, plus you've got healthcare background, and you also have an IT background. Where can you be most helpful? And I'm really glad that even though I really want to work in plan management, I was able to support the organization. So I think it's an asset to literally walk into cyber and really be able to contribute. So whether that's election security, whether that's public health, whether that's chemical, whether it's energy, so all these things can be hacked. And we're trying to make sure that the adversary, is out, but you really need to have that understanding. And then as a business owner, obviously when you walk into the organizations, they are systems, they are connections. So really understanding that is very helpful to the field. Kevin, did I answer the question? I'm sorry.
Right. Yeah. And you mentioned like everything can be hacked, and sort of the opposite of that would be resiliency.
There we go.
So I know you work a little bit in that space, and the White House has issued quite a bit on resiliency through some of its presidential memoranda. How can we move from this perimeter-based thinking to more security built in? How can we move from sort of hair on fire, oh no, there's a vulnerability, to, we have resilience, graceful failures, as opposed to, like what happened earlier this year with the major outage of computer systems. One of the big ones was CrowdStrike. One of the other big ones was Change Healthcare, where, you have a system that you think is running fine, but when it fails, everything seems to just fall apart.
Yeah.
So
Yeah.
is
Yeah.
anything you can comment on about resilience for better cybersecurity?
Oh yeah, absolutely, absolutely. And I think, I mean, obviously, I know we were focused on endpoints, but that's the point when I mentioned, obviously, even right now, I'm glad that there's medical device security that we're looking at. We're looking at different sectors, and I think that's really important. We really have to make sure that, everything that has a connection, literally, I think there should be, let me back up. One of the things I think that we did really well, we had something called the Harmonized Privacy and Security agreement that all the CIOs from the federal agencies actually signed. So they literally sat down before we were developing the Affordable Care Act to really agree on. So key organizations were brought in to make sure that before we even started the effort, that there was an agreement, that there was a harmonized agreement on privacy and security. Not that they said, here are the controls, but it really went back to the importance of why why these things were important and how interconnections were really important. And then obviously that it was about trust, but really trying to asking each one of the organizations to really grill down on what things could, obviously identifying, like you said, Kevin, not being afraid, but really kind of making sure that they had a handle on those things that were important to their business, that obviously, may have been an issue or was an emerging issue. So that was what the harmonized privacy and security document, I thought, was really in my eyes, really the way that I guided myself. And then when I worked with the contractors and the states and the others, I think, we were fairly successful because we had a baseline understanding that our agreements, our interconnected security agreements, our other things that were really important, why we might take a system offline, why it was important for them to be vigilant. And I think that really did from that, it just wasn't let's jump in and pick controls. It really started from the very top of the organization, which means some of those organizations had to make sure that their senior leaderships outside of just the CIO and the CISO bought in. And when we needed those persons' attention, we really got them. So when I think about each of these sectors, it's just not the CISO and it's not the CIO, it's the board and it's the other organizations really understanding how this impacts. So I think it's, really understanding what their risk, enterprise risk management is so important. And I think really starting there, the enterprise risk and really understanding what risk and those things that really would interrupt the business that they are in terms of obviously securing patients. So I don't know whether I answered your question, but that's the way that I kind of saw it.
Right.
And the whole governance of the piece.
Right. Well, we only have a few more minutes, and I know we have a lot of questions on other topics outside the space. You're welcome if you want to select one. I know some of them are on other subjects like medical device security. But we could also dive into a little bit of maybe a final question on governance and accountability in the executive space as well, if you'd like.
So Kevin, you're saying that there's some out here online. I'm sorry.
Oh, well, there are some questions. I think some of them are intended for me, but
oh yeah. Some of these are yours. I can tell you, medical device security is not.
But
yeah.
We've got actually we have a question about executive boards. So maybe it's a good time to turn to the executive boards, and for the questions about medical device security, that's probably closer to some of the other speakers or myself. But let me just raise the point, the SEC, for the stock exchange requires chief information security officers to report issues if their own leadership fails to adequately secure and protect key business assets. And, this could be IT and data. Of course, in the healthcare world, we have more OT. And if they don't, they could face penalties. And so I'm curious, what are you hearing from the field in this space? Is it all roses? What do we need to do? But we have just a couple more minutes, but maybe you could share some thoughts in that space.
Yeah, I'll be honest. I am really fortunate that in my executive program at Brown, a lot of these folks are CISOs. It's concerning, it's concerning because these folks really have a passion for cyber. I mean, and they live it 24 hours a day. And then if you think about it, there was something published, I think, in CISO magazine about just the level of stress. So on one side, obviously they're trying to make sure that that things are secured. But if they're not necessarily listened to, then obviously, do you tell your employer or do you beg your? I mean, either way, it almost felt like a no-win situation, So I don't know. I'm hoping that. I mean, I understand, I understand what we're trying to do. I'm not sure, in my opinion, whether that's the best way to do that. I mean, we already have, a shortage in the industry. I think there might be a better way. I'm concerned about folks not keeping with that top position. Now, one of the things I think is really important is that, I think for those for those CISOs that report directly to CIOs, I know that's important, but if you're going to make it that responsibility, then they should report directly to the CEO, and be able to report directly to a board. I think secondary reporting when you may be fined or in prison now takes your position from the reporting to a CIO to that board and the CEO. Very important. I know that's where I stand. I think you have to change that reporting structure so I'm more able to communicate if there's something else, and being able to talk to the board directly versus having to talk to the board, through somebody else. So that's a side that I am on. I don't know how anybody else feels, but I figure if I have to, stand up for the organization, and if someone's not going to listen, and now it's on me, I need to let the board. I want to go to the board and not to the person potentially that may not, where we may have sometimes competing, needs, because obviously everyone's trying to deliver something, and obviously profit margin's important. It's a new item, you want to get it out there. You could be the first at it, but security is not necessarily sometimes people think about it, and sometimes it's fearful. To be honest with you, for a lot of people, security is still something that people run from. Even senior managers and execs, it's still not comfortable. It really is. It's frightening. So I think we have to take that too, that we're still at the point where people want to hear from security all the time. We're getting there. But I think they are understanding how important. But I remember, there is fear. There is still like, oh, this security person's coming again, and this is happening. So I think we're growing. I don't know where we're at that place yet, where people are, where managers, executives are still embracing us as fully and being comfortable.
Well,
that's just my opinion, Kevin.
We're at the top of the hour, so unfortunately we have to conclude the session. I appreciate your remarks, Andrea. Thanks for coming to the program. I'm glad, I hope HHS and CMS can continue to work hard on some of these governance issues as well. So this is going to conclude today's UCSF-Stanford CERSI FDA seminar series on cybersecurity for biomedical engineering. And we'll resume on the third Thursday of November. Jan Kufner from TUV Sud will be speaking on pen testing for medical devices. So thank you again, Andrea.
Thank you, Kevin. Thank you all. I appreciate it.
All right. Goodbye, everybody.
Bye-bye.